Good morning, everyone. My name is Jeremy Pruzin. It's a pleasure to be here this morning to talk about new prospects in blood-based biomarkers and disease-modifying anti-amyloid antibody therapies for early-stage Alzheimer's disease. I'm joined by my distinguished colleague, Dr. Marwan Sabbagh, who will be presenting after I talk. A couple of housekeeping matters, so I'll let you read that. Not gonna go through everything. It's about ACCME credit and whatnot. Just pause for a moment. Okay. I will read this one. So in order to obtain CME CE certificate, so please, you must attend the webinar completely, after which you'll be able to participate in a brief evaluation and download your certificate using a link displayed at the end of the program, which needs to be done by August 10th of this year. This is a statement on conflicts of interest, which I will not read completely, but we'll pause for a moment. Okay. Again, won't read this one completely, but I'm talking about unlabeled use of medications or tests, and a disclaimer about responsibilities. So I'll pause for a moment. Okay, our learning objectives this morning are to summarize the pathophysiology and clinical presentation of Alzheimer's disease, to assess the blood-based biomarkers in diagnosing early-stage AD and its utility in prevention, and to identify strategies to optimize disease-modifying anti-amyloid antibody therapies in managing patients with early-stage Alzheimer's disease. Here's the agenda, vignette, I'll speak, post-test on the vignette, same pattern with Dr. Sabbagh, and then we'll have some time for questions. Okay, so I'm going to get started here. My portion of the program this morning is to talk about blood biomarkers in early Alzheimer's disease and then potential future utility in prevention. We're going to start with a clinical vignette. So a 63-year-old man with a history of hypertension comes for consultation. He reports rare word-finding difficulties, not really noticed by others, and sometimes walking into a room and forgetting what he would do. He's still working, driving, managing the monthly finances for his household without issue. He scored a 29 out of 30 on the mini mental status exam. And then he relays that he had heard about a blood test for Alzheimer's disease in the newspaper and that he was able to get this test as a direct-to-consumer test. The normal range for this test, which you've figured out at this point, is amyloid beta 4240 is greater than 0.170, and the value on his test, which he's brought today, is 0.110. He desires to start on lecanemab. He's already had an MRI that was ordered by a primary care physician and other medical history that would be consistent with being an appropriate candidate for this medication. So what are the next most appropriate steps according to current guidelines? And I'll pause for a moment. I'll give it about 10 more seconds, I suppose. All right, hope you had time to answer, and we'll come back to this. But for now, I'm going to jump into today's content. Okay, so the title of the talk again. I am a cognitive behavioral neurologist at Banner Alzheimer's Institute. I see patients, I do clinical trial work, and I do NIH-funded research. A couple of disclosures here. So there's the NIA-funded research. I'm a site PI for a clinical trial here, and I recently did an advisory board. Okay, to the fun stuff. So this is a classic slide that you may have seen before, often referred to as the Jack curves. I think it's important to start here. And the point of this slide is to understand that the process of Alzheimer's disease starts years, perhaps decades prior to the onset of symptoms. So we see here there is amyloid buildup in people who have normal cognition, possibly as early as, someone's 50s or before. They can have amyloid built up in their brain for many, many years before you start to see changes in tau, which are followed by atrophy, the beginning of cognitive symptoms. And then later on, you arrive at a clinical diagnosis of mild cognitive impairment or dementia. So in the context of this talk, blood biomarkers and early stage disease, I think this is really important to reiterate. And anybody who's in this field or attends talks on the topic is likely to see some version of these curves. So what about blood biomarkers? So this is a bit of a summary. Don't worry, I'm not going to read all those words there. There are sort of what I would say four main tests. You're looking at amyloid and ratios often, and then phosphorylated tau. And I would pay more attention to the species, the specific species, which is what we'll talk about. So that's when you see the sort of number after it, 217, 231, 181. And I'll briefly talk about what that means just to have an idea. And the other two tests that are frequently used in research are neurofilament light and gliofibrillary acidic protein, which I'll briefly touch on, but really pay attention most to the beta amyloid and phospho-tau tests. So a little bit more about this. I think it's helpful to at least have some understanding of the basic science. What is a beta amyloid ratio that's 42/40? So it's a marker of brain A beta pathology. So the 42 refers to the length of the amino acid, which is the sticky species, the one that forms plaques, the pathological species. But also produced in our sort of normal biology is a 40 amino acid length peptide. And this one is not or less prone to forming plaques. It's not formed or found in these when looked at in the brain. And so you get this imbalance in the disease, and a 42 length the 42 peptide amino acid length peptide, excuse me, is quote unquote the bad one. So that's what's looked for in CSF, and it has this opposite phenomenon. So you might be familiar. So if the A beta 42 is low in CSF, that means it's likely to be higher in the brain. The same phenomenon is true in the blood. It's sort of a simplified way to think about it, but you can think about, if the amyloid is stuck in the brain, it's not in the spinal fluid and it's not in the blood. So what does this mean for our ratio? So if there's more quote unquote stuck in the brain, there's less in the blood. Schematically over here on the right, these are not real numbers, just to help you conceptualize it. But if you have low A beta in the blood, that means it's likely to be in the brain. And when you calculate this ratio, you're going to get a smaller number. So the smaller number means you're more likely to have amyloid in the brain. And that's sort of how that test works. For phosphorylated tau, so what that means, the number there, 181, 217, it means that there's a phosphorylation at that specific peptide, at that specific amino acid, excuse me, which is a threonine, 217. So that's what that means. But, more conceptually, what happens to tau in the brain in Alzheimer's disease is that this phosphorylation happens. It's tau is stabilizing microtubules in the axon. Phosphorylation occurs. It becomes unstable, comes off of these microtubules, causes neurodegeneration, and then starts to aggregate, and that's how you get tau tangles. So it's really phosphorylation that's the sort of inciting event in this pathological tau cascade. I won't spend as much time as on neurofilament light or GFAP, but just quickly, so NFL is thought to be more of a marker of generalized neurodegeneration. It's a component of myelinated axons. And so you actually see the levels of this protein increase dramatically in other diseases, especially ALS, but you can also see it in multiple sclerosis and Huntington's disease, so it's a less specific marker. Another blood-based biomarker that you may hear about is GFAP. Thought more to be a marker of brain inflammation. It's a protein that's common in astrocytes. The exact function is unclear, but it's thought to represent inflammation and astrogliosis. Astrocytes do a lot of things, support the blood-brain barrier, get activated when there are insults, inflammation, and that type of thing. But these two are not used clinically really at all at the moment. So I think it's important to talk about classification. It's a confusing time, it's exciting time, but things are changing quickly, and it's not as simple as, oh, we have a blood test for Alzheimer's disease now. You really have to think about the specific category of the test. How developed are they? What should it be used for? What level of validation they have. And I think it's really important to think about this right now and to understand this for the blood test. So you have these three different classifications per the FDA. One is research use only. The other is a LDT, or a laboratory developed test, and IVD, which it stands for in vitro diagnostic devices, but it can also mean tests. And that IVD designation is the sort of most validated FDA, ready for prime time type test that you may think about with a lot of these other things that you test for, myasthenia gravis antibodies, for example. But it's important to know that most or all of the tests that we have right now are mostly in the RUO or LDT category, and we haven't arrived quite yet at the IVD category, which means that they're fully validated and really ready for prime time on a larger scale. So I wanted to illustrate this point just with one more slide. On the right, that box, red box vertically, it kind of shows that really none of these tests have this IVD designation except for one test that's out of Japan. Most of them have a research use only or no designation, and a couple of them have this LDT designation. So if you go to the Quest Diagnostics site, you can see they'll have this disclaimer that they don't, basically saying they don't have this LDT designation, that they're not fully validated and approved through the FDA. Now, that doesn't mean that we can't use them. It's just something to be aware of as time progresses, and hopefully we get to the more LDT type designation, or IVD designation, excuse me, but we're not quite there yet. So important to keep in mind when using or ordering or thinking about these tests. What are the advantages of blood biomarkers? Some of these are pretty obvious, right? It's less invasive than a spinal tap. There's no radiation involved like you may see with a PET scan. Cost should be cheaper. There's no radio tracers. You don't need a provider to perform a lumbar puncture. Access, this is a big one. So I think there are some mountain west states like perhaps Montana and others where you literally can't get a amyloid PET scan in the entire state. You can draw blood anywhere. These tests, because they're less invasive, cost less, and have greater access, would be easier to track longitudinally and to repeat them. Some of the disadvantages, so I think these are current and hopefully will be former disadvantages, but they're newer, they're less developed. We don't know quite as much, which makes their interpretation more nuanced. It can be tricky for people who aren't steeped in this every day, especially when things are changing quickly. How accurate are they? There's some tests that may be marketed as more accurate or promoted as more accurate as perhaps they are, and it's hard to know what test to choose given all the different options here. So a few words on test performance. So these are usually depicted as what are known as receiver operating characteristics with an area under the curve reported. And a couple of things to keep in mind, and this will make more sense. I'll give some examples. But what are these blood tests being compared to? Is it the gold standard autopsy? Is it to PET scan? Is it to other blood samples that have autopsy data so they're well characterized? But it's important, what's the comparison? And this AUC really, I think, is simplified, but it can be thought of as how accurate or how much agreement the assay being tested is to the comparator. How often do you get the same result, more or less? So here's a couple examples of these. So this is a phospho-tau 217. And on all the way left is comparing to A beta positivity these are three different cohorts or groups of people, the RAP, triad, and spin. And so they tested this against either amyloid PET or CSF. And when you're looking at amyloid positivity, you get this area under the curve that are quite high in these groups, ranging from 92 to 96, meaning that this test is really accurate in determining A beta positivity. Similar with tau positivity, that's that middle graph. And then C is kind of interesting to think about. It's people who have amyloid in their brain, but no tau. And so how good is phospho-tau 217 at finding these people, and which has implications for future prevention, because you want people at early stages with amyloid but no tau if you're going to target them perhaps with a therapy. And while not quite as good as when comparing to amyloid PET or tau PET or CSF, it does pretty well in finding these individuals. Here's another one of these examples. So this is a common test that you may see. So C2N is one of the companies, one of the more prominent companies offering blood tests, with A beta 4240 being the sort of more popular one. I'll point to the graph on the right there. So you see another one of these AUCs. You see that with just using the blood test, your AUC is 0.88, or sort of 88%. They added in ApoE4 status and also age into an equation to provide a amyloid probability score. So when you add those other two factors in, the test does better at predicting amyloid positivity. I will make a quick comment. So the A beta 4240 ratio, one of the issues with this test is that the dynamic range tends to be rather small, and so that can be kind of tricky when it comes to interpretation. And also, if you have variability with the assay, depending on the platform used, you're a little bit worried about scalability and making sure that you have the most accurate test. Nonetheless, it has been shown to be pretty predictive, and especially when you use these other two factors, and has been being used in clinical trials and otherwise to some degree at this point. So the diagnosis of Alzheimer's disease, how do we use these blood tests? So this is sort of hot off the presses, or not even on the press yet. This is a draft document that's open to comment that was presented at the Clinical Trials for Alzheimer's Disease in October. This working group trying to provide recommendations on how we use these tests, how we establish a diagnosis. I think most importantly, so that second bullet point, when we're talking about clinical use, so is this person appropriate for a monoclonal antibody? Not just are you likely to have Alzheimer's disease or not? And really, when right now, as the thinking goes, what are the best tests? What are the most acceptable tests to use when thinking about prescribing a monoclonal antibody? Amyloid PET, CSF testing with either A beta or phospho-tau, or a ratio of those, or quote unquote an accurate plasma assay, which is defined as basically a 90% agreement. So that AUC is 90% with 80 neuropathological change at autopsy, or near complete agreement with amyloid PET or CSF42. And the table on the right over there, it has one of those such tests for plasma, or two really, but they're both based on plasma p-tau 217 as being the sort of best performing test at the current science to determine amyloid positivity. So potentially that could be used in the near future. The others right now are not recommended for, although another word on that in a second when it comes to the appropriate use recommendations. I want to make sure everyone continues to be a clinician. This is another piece of information that should be used. This is also from that same paper, the working group, and that it's important to use your clinical judgment. Somebody has a positive amyloid test, but also has REM sleep behavior disorder. They're seeing little people and they have Parkinson's on exam. Well, then it's very likely they have co-pathology, and you have to take that into account. What's driving the presentation? What is your clinical judgment here? Same thing for vascular disease. We don't have any blood biomarkers for vascular disease really ready. So, how do you take that into account, and what do you do with that? And I don't think there are great answers, but that's what we need to do as clinicians, and to put these tests in a context of a person and not just say, the test is this, that means that. So in the real world, so I was saying plasma p-tau 217 is about there, and that likely, at some point it'll be good enough to prescribe a monoclonal antibody, but not at this moment. So right now, the appropriate use recommendations are that you get CSF or PET testing if the goal is to prescribe a monoclonal antibody like lecanemab. And this is a couple quotes that sort of illustrate that, so that the blood biomarkers are getting better and may become fully validated soon, but at this moment right now are not considered adequate to identify appropriate treatments, patients for treatments. The converse, so they have pretty good negative predictive values, and of course the risk is much less if you're not going to treat, or you're going to tell someone that they don't have amyloid and wouldn't be appropriate for a medication. So in that scenario, to rule out Alzheimer's disease, they are thought as ready for prime time in that sense. So how might I use this test? What are the real world? So if you think about plasma A beta 4240, I have somebody comes into the office, the clinical suspicion for Alzheimer's disease is low. They're relatively young, let's say, early 60s. They don't really have any detectable cognitive or functional declines. So you're thinking this is a person that's likely worried well. You can get an amyloid 4240 ratio. It's very high, meaning the amyloid probability score is very low, and then this would make Alzheimer's disease very, very unlikely, and this would satisfy me that no further assessment is necessary at this time. In general, I mentioned age there. You always want to take into account a person's age as people get older, so approaching age 85, it's about a coin flip whether they're going to be amyloid positive or not. And so that's that sort of clinical judgment. These tests, to me, whether it's PET, CSF, or otherwise, plasma are much more informative and helpful when somebody is younger as opposed to when they're in their 80s. So always something to keep in mind with whatever type of test you're using. What about plasma p-tau217? Well, here's a scenario, an early amnestic syndrome consistent with AD. They're on anticoagulation. They don't want to get a PET scan, can't do a lumbar puncture. They do want an accurate diagnosis. They're also, anticoagulation right now per appropriate use recommendations would preclude them from getting a monoclonal antibody treatment. So in this case, why a PET scan, why CSF? When you can get p-tau217, which is as good to make a diagnosis. So to me, this would be an appropriate use of p-tau217 at current time. So if a patient is interested in lecanemab, however, as I just mentioned, the current appropriate use recommendations are to get CSF or PET, although I imagine this is likely to change soon, but we're not quite there yet. So stay tuned, and perhaps we'll have to repeat this webinar in 6 months or a year as things change. Let's talk about prevention a little bit. I think this is an exciting area that it seems that the treatment with monoclonal antibodies and otherwise is likely to work better the sooner the treatment is given, whether that's in symptomatic or perhaps in asymptomatic people, will find out. But why are the blood biomarkers important? So the two curves all the way to the left are CSF and plasma A beta 42. You can see that changes first, but that's followed shortly by CSF, plasma p-tau, and total tau. So it's really these blood tests along with CSF that reflect the earliest changes of Alzheimer's disease pathology, and not PET scans, which I think is great news, that we can likely go to blood tests to track when people are developed, when pathology is brewing, as opposed to PET scans. Again, we can repeat these, we can track these a longer term, and we can detect them very early. So this is, I think, good news for the field and encouraging for prevention, which is hopefully coming in the near future. I do need to mention that there are currently no approved prevention preclinical therapies. There are two ongoing clinical trials examining this. But right now, if somebody has a positive blood test in the absence of any symptoms, any neuropsychological assessment showing mild cognitive impairment, the current recommendation is to not test for amyloid, which is more and more of an issue. So, if it's a lumbar puncture or a PET scan, those are more involved. People are less likely to seek those out who are completely asymptomatic. But if you can just get a blood test relatively cheap at a direct-to-consumer, you could definitely see that happening, and it already does. So something to keep in mind right now, there are not approved prevention therapies. That may change, but testing asymptomatic people is currently recommended against. So I mentioned these trials. I'll spend a couple more words on them. There's Trailblazer 3, which is using donanemab, and AHEAD 345, which is using lecanemab. These two trials actually use these blood tests. So in Trailblazer 3, it's the p-tau 217 assay, and for AHEAD 345, the C2N Precivity's APS score is used, but then that was later revised to include p-tau 217 because it just seems like that is a little bit better performing test. For the Trailblazer 3, that's it. There's no PET scan. You just have the blood test. The setup of AHEAD 345 is a little different in that the participants are stratified into sort of a low amyloid and high amyloid group, and so they do go on to get a PET scan for that classification, but nonetheless, this is the initial screening tool, are these blood tests. So these are being used now in these clinical trials that are ongoing. A little word about, how early do these change and how do we know? So autosomal dominant Alzheimer's disease, so genetic mutation, people are destined to, on average, develop MCI at age 44 or dementia at age 47. So these blood tests were tracked over time in these mutation carriers because we can predict when they're likely to develop disease and then understand the timing of the changes of the blood test. So you can see here that p-tau 217 starts to change at about age 25 in carriers of this mutation, and it gradually increases from there, and that's 20 years prior to symptoms. So, this was exciting when it was found that we can really detect these changes very, very early through a blood test in this remarkable resource of these participants who unfortunately, are in a extended family that suffer from autosomal dominant Alzheimer's disease. So what about in sporadic Alzheimer's disease? But this is preclinical, meaning people have amyloid in their brain but no symptoms. How do these tests perform in this population? So I think most importantly, I'll direct your attention to the top right, that graph at the very top, where you see that people with high p-tau 217 who when this was first drawn were completely normal, so to speak, no cognitive decline, etc. But then their high p-tau 217 over the course of years predicted a decline. You see the slope of that graph that's looking at cognition, whereas if you compare that to the low group, those people stayed steady. Their cognition didn't change. And then in the middle there, and if you look at the slope, there's sort of an intermediate effect for people who have a mid-level of p-tau 217. So this blood test seems to be able to predict who's at risk for cognitive decline in the coming years, which is incredibly exciting. So what's the future? So this is my opinion. These two trials that I've talked about that are looking at prevention with the idea that the earlier you treat, the better. Trailblazer 3 and AHEAD 345, I think they are likely to show benefit. And so we need to think about as a field and prepare as people who treat patients and want to make a difference on the ground. What does the world look like with an FDA-approved prevention therapy? I think, sort of the goal or the thought or my hope is that you get regular monitoring with one of these blood tests. We can understand when these start to change. It's sort of analogous to cholesterol. If you start to see changes in cholesterol, you take a statin, and that's going to prevent you, hopefully, from having a heart attack or having a stroke. So could we conceive of a similar model in Alzheimer's disease? That's my hope. I think that's the hope of the field, but there's a lot more work to be done. These trials are hard. They take a long time. We need to track people for long periods, but we're learning a lot and we're making progress. And so stay tuned. So thanks, everyone. So I'll put up that vignette again. 63-year-old man, hypertension, has word finding, and walking into a room and forgetting why. Still working, driving, managing monthly finances, did well on the MMSE, got this direct consumer test that he comes to you with, has a normal, his ratio is quite low, and he wants to start on lecanemab. He's otherwise appropriate in terms of MRI and other issues. What's the next most appropriate steps on current recommendations? And I'm not sure if I'm supposed to give the answer at this point or we want to wait.
Yes, you can do that as soon as I end the poll.
Sure, perfect. And I'm assuming it'll pop up when the poll's ended. Okay, there we go. All right, I like it. This was a tough one. And so the correct answer, and I'll explain why, is E. So refer for neuropsychological testing. If there's abnormal cognitive decline, meaning this person has mild cognitive impairment, then you discuss lumbar puncture or a PET scan. So why is that the best answer? So, this person may be at the earliest stages of mild cognitive impairment. The MMSE doesn't pick this up. They have the subjective experience and some degree of symptoms. But again, MMSE, not a very sensitive test, but they may be in the earliest stages of mild cognitive impairment, and they may be very likely to benefit from lecanemab, given that the ratio is low and they likely have amyloid in the brain. So if they go to neuropsychological testing, get put through the ringer, and it shows decline, again, they have a diagnosis of mild cognitive impairment. Given current guidelines, the blood test isn't good enough to prescribe lecanemab, and so you'd have to proceed with lumbar puncture and PET scan, which if that confirmed amyloid positivity, then they would be a candidate, right? If there's no abnormal decline, they are asymptomatic. This would be sort of more of a prevention type territory. So that makes D incorrect. C, again, I think you need to establish a diagnosis of mild cognitive impairment first. And it's hard to know based on the history and the MMSE. So they need more testing in my mind. B, no, we're not just going to tell him he's doing great, go exercise. And then, A, there's more to do before we get to that possibility. So, all right, I think without, let's see here. Yeah, so next up is colleague and distinguished professor, Dr. Sabbagh. I'll turn it over. I'm going to stop sharing here.
I am Marwan Sabbagh. I am a professor of neurology and vice chair at the Barrow Neurological Institute. Today, I'm going to talk about clinical trial data on safety, efficacy profiles of approved and investigational disease-modifying anti-amyloid antibodies. And I want to thank Dr. Pruzin for an excellent first session because that sets up this conversation rather well. Let's start out with a case, my case, as opposed to, which is a little different. A 77-year-old right-handed female with 16 years of education referred for evaluation of cognitive changes. History is obtained from the spouse. Symptoms have been present for 2 years, initially manifesting as getting lost driving. She's noted to have less ability to do banking, including depositing checks. She has trouble using a computer. She forgets her passwords. This has been progressing over time. She relies much more on notes and memory aids. In 2018, she could not locate her car in a parking lot. She does lose her train of thought when filling out forms. In general, she's doing well on most other activities, but she's very anxious when she's becoming forgetful. She now needs a shopping list when she's shopping. We do an instrument called the Alzheimer questionnaire, which is an informant-based questionnaire on capturing incident cognitive decline, and she scores a 12. Normal is below 10, is below 5, and 10 and above is considered impaired. Functional assessment staging, which is the staging instrument of severity, puts her somewhere between a 3 and a 4, which puts her in somewhere in the range of mild cognitive impairment to mild dementia. The Lewy body clinical rating scale is 1, which means a very unlikely to be Lewy body dementia. 6 and above is considered consistent with Lewy body. 3 and below is considered not. So she is having confusion, short-term memory impairment. Let me get to that before we go to the pretest. The short-term memory, agitation, frustration, anxiety, personality change, obsessiveness about health. There are no impaired attention, concentration, difficulty speaking. There is some word-finding difficulty. Long-term memory there are no reports of it, hallucinations, delusions, etc. Her MRI was no acute disease, but her medial temporal lobe was in the 3rd percentile. There's no microhemorrhages noted. Her B12 and TSH are normal. Her homocysteine is normal. So now, when selecting if the patient is suitable for lecanemab, which of the following is important consideration? All of them are considered important except Okay, so hold on to this. We're going to come back to this a little bit later. So I'm going to talk a little bit about the monoclonal antibodies and how we got to where we are and how it makes sense. Again, to Dr. Pruzin's presentation sets this up very well. We're going to talk about the anti-amyloid therapies. These are my disclosures. I have proprietary interests in a few companies. I consult. I have many grants of my own. So we have had for the last quarter century the symptomatic drugs. These are drugs that improve the symptoms but don't change the trajectory. That's the purple hashed line. And the idea is that the patients get better from a drug like a cholinesterase inhibitor or an NMDA antagonist, but it doesn't fundamentally alter the trajectory. We project the possibility of the green dotted line where we have a true disease modification, or the ideal scenario is the combination of the disease modification and the symptomatic. This has been postulated for years and years, and we hope we're finally coming upon that possibility. But people do not realize is that we didn't suddenly come to a monoclonal antibody. If you actually look at this slide here, these are all the drugs that have failed in the last 20 years. In the phase 3 program, this is 40 billion with a B, 40 billion US dollars of investment. It's not like we haven't been trying, we're just going about it wrong, or that the drugs fail on their primary endpoint. And this is a variety of categories of drugs, from statins to secretase inhibitors to monoclonals. Now, we're going to talk about how we got to a monoclonal, but we understand amyloid biology very, very well. And amyloid biology is not something we just think of as a slow, uniform, unidirectional process. We used to think that you just kind of create it and become a plaque. But then when Randy Bateman put lumbar catheters in patients and realized that amyloid biology is very, very dynamic and that the diurnal variations of amyloid are huge. What we do know is that we cleave amyloid, the amyloid precursor protein, that's the purple square, and we create the monomeric A beta. It goes through a multi-step sequence to become a oligomeric species, which then becomes a fibril plaque and then synapse plaque. We have improving, reducing production or improving clearance. And what we also now, if we can take 25 years of research into consideration, we know that the monomeric and dimeric species of amyloid are nascent proteins, meaning the brain does not react to them. It's only when you get to the oligomeric species that the brain starts to get the microglial activation and the inflammatory response, etc. So we know that we really want to target anything in the clearance-based approaches at the oligomeric species or later. So the reason it's important is that you could just say, well, why don't we try to, instead of enhancing clearance, and that's the bottom of the slide, let's inhibit production. And that's the two enzymes is beta amyloid cleaving enzyme or gamma secretase inhibitors or modulators. And I will tell you very clearly in that large slide, we tried that. And for the most part, no, for all of it, the base inhibitors and the GSMs and GSIs, that's gamma secretase modulators or gamma secretase inhibitors, have not only not worked, they actually made patients worse. So we know that the production-based approaches, at least right now, have not worked and not been successful and not ideal. And so we have been looking at focusing on clearance-based approaches. So the reason we bring this up is that in the late 90s, my distinguished colleague Dale Schenk said, what if we look at Alzheimer's disease as a infection? And he created the first vaccine called AN1792. And if I show you this slide, and I had given you this talk, we would have said, I think we've cured Alzheimer's disease because the first vaccination clearly showed that they could remove amyloid, and we thought this was it. We were done. Now, the fact is that we realize now, 20 plus years later, that humans are not the same as mice, and we've cured Alzheimer's about 100 times in mice, but never in a human. And So this study was very important because this was the first active immunotherapy preceding the onset of monoclonal antibodies. And the active immunotherapy that was done enrolled, I'll never forget this, 360 patients in about 6 weeks. A typical trial of that size takes about a year to enroll. That was October of 2001. We started hearing about problems in January of 2002, and then by March they had stopped the study. And why? It's because they had 18 cases of encephalitis and 5 deaths. And so people get a little worried about that, and that's appropriate that you worry. But what they showed, this is the Nickel paper, is that amyloid was actually removed. And so this was a successful study suggesting that you can target amyloid. And the fundamental issue now that we understand AN 1792 is that you could not regulate immunogenicity, which is why they said, let's stop doing the active approach and go for the passive approach. And so after 2004, they decided to go for creating monoclonal antibodies. And the first 2 monoclonal antibodies were bapineuzumab and solanezumab. And so I will tell you that bapineuzumab was the first study that we did. And what we show here is that for the first time ever, we showed that amyloid was removed. As you look in the upper left-hand panel, you see that the placebo group showed that you could remove amyloid. That's the red line. And if you look at the bottom left-hand panel, you showed very successfully that you could pre and post-treatment, you could remove amyloid. Now, what you see on the right-hand panel, though, is that the amyloid, despite removing amyloid, you saw 0 clinical effect. And this is a very frustrating finding, is that it was a negative study. But we didn't understand a lot at the time, and we've learned and learned and learned along the way. And this paper was published 10 years ago. The reason we learned is that this was the phase 3 clinical trial. The phase 1 trial, which was done in 2005, 2006, was using 5 and 10 milligrams per kilogram. And we, for the first time ever, I'll never forget, because I was one of the very first persons to see ARIA. We didn't know what this vasogenic edema was. It scared the heck out of us. And so we saw a lot of ARIA with phase 1. And phase 2 and then phase 3, we kept lowering the dose. And so by the time we got to phase 3, we were not at 5 and 10 milligrams per kilogram. We were at 0.5 and 1 milligram per kilogram. We had effectively reduced the dose 10x. And some people interpret that the reason this drug didn't work is not because it didn't target amyloid, but it's because we dropped the dose too low because we were afraid of ARIA. Now, at the same time, we were seeing the development of another monoclonal antibody, which was called solanezumab. Now, I want to say the difference in bapineuzumab and solanezumab is that bapineuzumab targeted the plaque. Remember, I showed you the pathway before. The plaque, this was the end stage. This was a monoclonal that was the end terminal, meaning that it targeted the final product, which is the senile plaque. In contrast, solanezumab targeted the monomer. And showed in their Expedition 1 and Expedition 2 trials that they could slow the rate of decline by about 30%. It was a very small effect. As you see, these are tiny, tiny effects, but statistically significant. And so they made a decision at that time to go into their Expedition 3 study. And the Expedition 3 study enrolled thousands of people and showed that they wanted to get their pre-specified delta on the cognitive outcome measure, the ADAS, was a 15% difference between placebo and not placebo, and they only got an 11% effect difference between placebo and not placebo. I remember being in the room when $1 billion of investment and the company decided to walk away from this drug. So solanezumab targeting monomers didn't pan out and was not approved and never moved forward. I will tell you the other drug that targeted monomers is crenezumab, again showing no efficacy signal. And so we know that targeting anything less than an oligomer has not shown any clinical benefit. Fast forward to 2000, into the 2010s, we started to see a very robust, consistent signal of removal of amyloid. This is the Marguerite Road and Scarlet Road AD trials showing that when you gantenerumab could remove amyloid and do it very, very well, as you see in the upper right-hand panel on the bottom. And so we knew that we could do it well, but this drug did not meet its pre-specified endpoint, and they, instead of walking away from it, the company decided to go in the opposite direction. They decided to increase the dose, not decrease the dose. So the Marguerite Road and Scarlet Road AD trials had 220 milligrams a dose, but when they went to their phase 3 trial called the Graduate Study, they increased the dose 5x, 1,200 milligrams, and they showed again that they could remove amyloid and do it very, very well. But the Graduate Study had a pre-specified endpoint of a 25% difference between treatment and placebo, and they only had an 8% difference between treatment and placebo. And again, $1 billion later, the company walked away from that investment. So now we get into the approved drugs, and I know you've been following this space very well. The first drug that was approved was aducanumab, and it's been again in the news of recently. Aducanumab was unlike other ones, which are murine-based, meaning that they're based in mouse models. Aducanumab was a different one. Aducanumab was found a population of humans that had natural immunity to amyloid, and they derived this monoclonal antibody from that. And what they showed in the Sabbagh paper published in Nature, and I want you to understand that you can't publish anything in Nature. It is next to impossible, and clinical papers are even more next to impossible. It showed the first time ever in the left-hand side, in a dose-dependent manner, the more amyloid was removed. That's the left-hand panel. In the middle panel, it showed that in that same dose-dependent manner, that the higher the dose, the more slowing in the rate of decline, and you see absolute clearance of the amyloid on the right-hand side. So we knew that that we could do something we had never done before, which is called directional concordance, meaning that in a dose-dependent manner, the higher the dose, the more amyloid was removed, and the more slowing of the cognitive decline. Now, what happened after that is that they skipped a phase 2 trial and went straight into a phase 3 trial, and they did 2 phase 3 trials, the Emerge and Engage studies, showing that they could remove amyloid and do it very, very well, as you see on both Emerge and Engage, but they did not hit on one of the 2 efficacy endpoints. So the Emerge study was positive. That's the middle column, suggesting that they had 22%. That was statistically significant, but the Engage study was not, did not meet its pre-specified endpoint, effectively saying that it was a split outcome. Now, what happened after that is that they negotiated there was a lot of controversy, but fundamentally what the FDA did is they approved the drug on the biomarker endpoint. So what they did is they gave it accelerated approval like they do with cancer drugs. They basically, a cancer drug gets approval not on its clinical efficacy endpoint, but on its biological endpoint, like shrinking a tumor marker. And they showed for the first time ever that they could remove amyloid. That is what got the drug approved. Now, Medicare never, ever paid for it. And I could spend the rest of the hour kind of just talking to you about all the controversies that ensued after that. But I'm trying to say is that the regulatory path that got the drug approved had nothing to do with whether the company was negotiating a deal with the FDA. Has everything to do with the fact that they used a different regulatory path, a cancer regulatory path, to get the drug approved. At the same time, you saw the development of another drug called lecanemab in development. This is now called Leqembi. This is the phase 2 trial, which was a dose-finding trial, which showed that when you use a Bayesian analysis, they could show slowing in the rate of decline on their composite measure called ADCOMS, slowing up to 30% when you dosed it at 10 milligrams per kilogram biweekly, and it worked very, very well. This is a huge phase 2 trial, an 800-patient phase 2 trial, which is very atypical for a phase 2 trial, but it was very successful. In fact, they did exactly what they intended to do, which showed that they could find the dose they were looking for. And when they did in the phase 2 trial, showed very robustly that they could remove amyloid a lot. And that's the red line compared to the blue line, which is the placebo, which removed no amyloid on CSF and PET. That's what prompted them to go into their phase 3 trial, which was known as the Clarity trial. And the phase 3 trial was done in almost 1,795 patients who had mild cognitive impairment or mild dementia and were randomized and biomarker confirmed, randomized 1-to-1 to lecanemab or to placebo. I want to point out to you that these patients are on, most of them, 60% of both groups were on background therapy. So this is lecanemab plus standard of care versus placebo plus standard of care. So these are not true placebo patients. They actually are on background therapy. And what they showed is on the regulatorily preferred instrument, the CDR, the Clinical Dementia Rating Scale, that they slowed the rate of decline by 27%, which was very, very robust, highly statistically significant. And if you look at this slide, which was published in the New England Journal paper, I was fortunate to be a co-author on, showed that they were statistically significant starting at 6 months at every single time point. What they also showed very, very, very robustly is that they could remove amyloid and do it very well. And if you actually look at it, up to 75% of the sample was amyloid negative by the end of the study. So we know we could remove amyloid and we could do it very, very well. What they looked at the activities of daily living scale, they showed that they could slow the rate of loss of functional decline by up to almost 40% compared to placebo. So that's a real impactful thing. Is not we didn't just simply see it on a global measure like the CDR, but we also saw it in a functional measure that it slowed the rate of loss of function almost 40%. The next drug you need to be aware of, so I want to be very clear that lecanemab got approved on January 6th of 2023 under accelerated approval pathway under the brand of Leqembi, and now got full approval in July 6th of 2023, and it is now fully available and is reimbursed by Medicare, and actually have many patients on lecanemab. Let's talk a little bit about the emerging disease-modifying therapies. The one that everybody needs to be aware of is donanemab. This is their phase 2 trial called the Trailblazer study, showed that on their composite measure called the iADRS, they could slow the rate of decline 32% and do it very, very well. They actually showed something very robust, is that they could show that by almost 2/3 to 3/4 of the sample had no amyloid in their brain by the end of the study, and it correlated well with the reduction of plasma tau. And this is going to be very, very important for you all to understand, is that p-tau levels are critically important. And this is all their data. They hit on their primary composite measure, and they hit on their secondary measures, including CDR, some of the boxes, a cognitive measure called the ADAS-Cog, and the activities of daily living scale. When they went to their second Trailblazer 2, ALZ2, they actually looked at all of their study and showed that they hit on their pre-specified endpoint, delta also showing a high difference between donanemab plus standard of care versus placebo plus standard of care, but they stratified their sample by the level of tau in their brain. And what they showed is that it did have a good effect in a modest effect, but positive effect in high levels of tau. But if you had low tau or moderate tau, you actually had a robust, super robust effect. And in fact, one of that subgroup actually had no decline after a year in up to half of the patients, and it had very slow lowering in the activity of daily living scale. So what I'm trying to say is that by selected subpopulations, this group did very, very well. And what they showed is that by up to 6 months, as early as 6 months, there were a lot of patients that had no amyloid, because the donanemab removes amyloid and removes it very, very well. And up to 71% of patients had no amyloid in their brain by 12 months. Now, we're going to talk a lot about ARIA, because donanemab has more ARIA than lecanemab, and you see the range here, but the ranges are somewhere 12% if you're a non-E4 carrier, heterozygote 24%, of 44% for E4 carriers, and microhemorrhages as well. Now, I commented earlier about p-tau, plasma p-tau, and this is, again, Dr. Pruzin's comments set this up very well. p-tau, what we do understand, when you look at the totality of scientific evidence, we know that amyloid does not correlate well with clinical progression. It is actually the spread of tau that correlates very well with clinical progression. So the concept here is that, people then say, why are we spending our time, why are we spending our effort removing amyloid? Well, the answer is maybe that the clinical efficacy signal that I just showed you has less to do with the direct removal of amyloid correlating with clinical progression, and more with the fact that once you remove amyloid, other biomarkers actually get better. And you see here in a almost linear correlation, a correlation between the reduction of amyloid and this lowering of p-tau. And the p-tau correlates very, very well with clinical progression, and that's probably why you see an efficacy signal. So what have we learned? Before we say victory, you have to understand that you have to select patients in the very, very, very mildest, so mild cognitive impairment and mild dementia. 2 is you have to look at their ApoE4 carrier status, because we know that in a dose-dependent manner, the more ApoE4 alleles you have, the likely you are to get ARIA, and you have to do biomarker confirmation, and you have to do risk stratification and risk management for ARIA. So what is ARIA? Amyloid-related imaging abnormality, and there are 2 types, ARIA-E and ARIA-H, and you see on the left-hand panel, ARIA-E, this is vasogenic edema, ARIA-H is microhemorrhages. I will tell you that ARIA-E and ARIA-H, first time you see it, I got scared when I saw it for the first time. Interestingly enough, up to 75% of people who get ARIA-E or ARIA-H are asymptomatic, and therefore you just manage it by watching. You stop the monoclonal for a while, let it pass, and then you could even think about redosing. Only in about less than 10%, about 6%, do you see clinically symptomatic ARIA, and that might be headache. You might get a little confusion. And so these are the things that might need more observation. But my point is that ARIA now is considered to be mostly asymptomatic and is easily managed. So the ARIA rates, as I comment, depend on the drug and depend on your ApoE4 carrier status. On the low end, ApoE4 non-carriers have 8% in lecanemab, and then you see the differences in the donanemab is a little higher. And so what I'm saying is it is drug dependent and allele dependent. So let's talk a little bit about the drugs in development now. My colleague, Dr. Jeff Cummings, publishes this every year. This is the 2022 showing you that there are 140 drugs in clinical trials for Alzheimer's disease, and you see the outer ring is the phase 1, the middle ring is phase 2, and the inner ring is phase 3. The biologics are on the top triangle, and then disease-modifying drugs are on the right-hand side. So there are a lot of drugs. Not all of them are targeting amyloid. A lot of people said, why are you targeting amyloid? Why don't you target tau? Well, there's a lot of reasons. First of all, we have been trying to target tau. It turns out that it's hard to get drugs across the blood-brain barrier. And then it's even harder to get not only through the blood-brain barrier, but get them into the neurons themselves. So drugs that have tried to do microtubule stabilizing or kinase inhibitors actually have not worked because you can't get them into the neuron. So a few years ago, there was the concept of, instead of just going for getting tau drugs, they said, well, what is tau at the end of the day? Tau is what's called a microtubule stabilizing protein. So you have these large proteins called microtubules, which are responsible for trafficking proteins and other things up and down neurons. So the idea is the tau are the proteins that keep the microtubules stabilized, and that they undergo a biochemical transformation called hyperphosphorylation. And when they do become hyperphosphorylated, they stop binding to the microtubules, and then effectively the microtubules disassemble and the neurons literally fall apart. And then these little phosphorylated tau proteins are kind of released into the extracellular milieu and taken up by the adjacent neurons in a process called preanosis. And that is the prevalent theory of the moment. Preanosis makes a lot of sense. And so that's why they started developing monoclonal antibodies against these free forms of tau, and most of them have not been very successful. So we know that we want to target tau because tau correlates well with clinical progression. If you look at the Braak staging scale and tau PET, there is clear evidence that the spread of tau correlates very well with clinical progression, and that's why it makes sense to target it, but it has not been very successful. Other drugs that have been looked at include, most people not realize that Sorexovant, also known as Belsamra, is approved to treat sleep-related disturbance related to Alzheimer's disease. So a lot of patients have sleep disturbances, and you can use a drug like Belsamra or Sorexovant to treat the sleep-related disturbances. I will tell you, I like Sorexovant if I can get it paid for. In 2023, most people not realize that a drug was approved to treat agitation called brexpiprazole or Rexulti, which is approved to treat agitation, and again is now available for agitation. There are now subcategories, including the homozygotes, which may respond to different drugs, specific aggregation inhibitors, and other things as well. So I know that Dr. Pruzin commented on prevention. It's a big area of research. And he said the two that are still ongoing are the Trailblazer and the ADCS AHEAD study. These are super important studies because we think that's where we need to go with this. So with that, I will now go back to my case. So we talked about a 77-year-old female with 16 years of education, has had series of cognitive decline, got lost driving, less ability to do banking, depositing, including depositing checks, forgetting her passwords on her computer. This has been getting worse. Once she couldn't find her car in a parking lot. She feels very anxious when she's forgetful. We talked about the Alzheimer questionnaire, her functional assessment staging scale, which puts her somewhere between mild cognitive impairment and mild dementia, and she does not have Lewy body. There is no episodic confusion. There is episodic confusion, short-term memory impairment, but no impairment of attention, concentration, fluency, long-term memory, hallucinations, delusions. MRI shows no microhemorrhages, mild atrophy, some neurodegenerative features with a third percentile on the medial temporal lobe. And which of the following, when selecting a patient for lecanemab, which of the following are important considerations? Please answer. Moderator, you'll let me know when I can.
Yeah, I'll end it here in 1 second.
So, the answer is E. So, I want to be very clear that you need to confirm amyloid status by PET or CSF. I know Dr. Pruzin actually commented on that, and we're close to using plasma as sufficient evidence, but we still, at this moment, according to the appropriate use recommendations, need to make that confirmation by amyloid PET or CSF. We do know that microhemorrhage quantity can predict the risk of ARIA, and so if you have 5 or less, you're safer from developing ARIA, and 10 and above would be a no on use of the lecanemab. ApoE, I spend a lot of time talking about it. If you're a homozygote, your risk of having ARIA is very high with lecanemab, up to 33%. And if you're a non-carrier, it's only 6%. So ApoE carrier status is important. As I said, the label is for mild cognitive impairment and mild dementia. And then, but the thing that is ironically not relevant is how much the patient complains about their cognitive decline. So you're right, 28% of this got it right. So those are things to think about.
Thank you for that great presentation, Dr. Sabbagh. I don't see any questions from the chat right now, but please, if anybody has any, let us know. I think I can, from my standpoint, to maybe get us started, or at least try to give some take-home points, some summaries from the blood tests and what I really want people to make sure they understand from what I presented. So a couple points that I'll just reiterate from my standpoint is that, right now, in a clinical sense, that we should not be getting blood tests in asymptomatic people. So I think that's important to underline because people, there are these direct-to-consumer tests. People may show up with already a result, and it's hard to know what to do with that. But if somebody is asymptomatic and that's been proven by neuropsychological testing, we don't have a treatment, and so we shouldn't be getting a blood test. And that's sort of the current thinking. That corollary to that is that the blood tests are sufficient right now to rule out Alzheimer's disease. So your suspicion is low, somebody's young, you get a negative blood test, either A beta 4240 or plasma p-tau 217, which isn't consistent with not having Alzheimer's disease, that I would be comfortable with saying you do not have the disease. Congratulations, come and see me if perhaps symptoms develop, or we have an approved therapy for prevention in the next few years. These blood tests are good and getting better, but they're not good enough right now to prescribe lecanemab or another monoclonal antibody. And in order to do that, you would have to obtain CSF or PET. But, sort of putting those 2 points together, you can rule out the possibility of prescribing it with a negative test, right? So again, but if you want to prescribe lecanemab or potentially donanemab in the future, need to get CSF or PET right now. And then in general, if you do want to use a blood test, current thinking, in my opinion, and I think the science bears this out, sort of the best test right now is plasma p-tau 217. I didn't emphasize this too much, and I'll comment on it here. In plasma p-tau 217, so you think, oh, well, it's a tau species, it's testing tau. But I did show those areas under the curve, and otherwise, it actually is a really, there's two things going on. It's a really good predictor of amyloid in the brain, which is really what we're doing for purposes of making that biological diagnosis and for also prescribing lecanemab. And that, but it also has a second advantage. So don't think of it as just a tau test. It really is a test that can demonstrate pretty conclusively up to 90% or higher that there's amyloid in the brain. So that's one thing that may be a little bit confusing, but to keep in mind. At the same time, it shows that when we remove amyloid and we have a clinical benefit, that biomarker is driven down. So it does both. It'll predict amyloid in the brain, but it also track sort of disease progression, treatment effects, and the sort of dynamic tau processes. So for that reason, it's kind of the favorite. Again, though, the field's changing quite a bit and all of that, but I wanted to make sure to reiterate those points. If you learned anything today, hopefully from my perspective, that was it. There's one question that maybe Dr. Sabbagh, you want to take. Somebody's asking about donanemab and when might be expected to be approved.
Yes, so we were expecting it to get approved in December, and the FDA postponed it, and supposedly still in this quarter of 2024, they're supposed to render an opinion. So I expect it to be approved by the end of next month.
So pretty soon. So stay tuned.
Pretty soon, yes.
Yeah, and I think that kind of raises a question too, is something we didn't discuss at all, but might be worth touching on. We don't really know. We don't have data. What do you do in the donanemab trial? Amyloid was removed. You have a negative PET scan, and then no matter what, you go on to placebo. So once you've hit that threshold where the sort of cleaned out of amyloid, you stop. Well, lecanemab, it was continuous treatment for 18 months, again producing a negative PET scan. What do we do when somebody has a negative PET scan after treatment with these drugs? Do we continue or do we not? And we don't have good clinical data, so it's going to be a bit of a journey to figure that out.
Yeah, so I want to tell you that this has not been decided. I mean, what was done in the trials is not going to be, doesn't necessarily inform what we do in clinical practice. So I think that there are a couple of possibilities. One is that we just stop treatment. In others, we would switch to sub-Q with lecanemab. A third option is we put them on some third TBD maintenance dose. So that's still unclear.
We got another question. So this is a good question, important. Are any of these going to be available for more advanced stages of Alzheimer's? I'll let you start on that one, Dr. Sabbagh.
Yeah, I think, Dr. Pruzin, that the answer is probably not. I think the totality of the evidence is that they only work in the mildest stages of the disease, and that all the evidence suggests that they will not be approved or used in more advanced stages.
Yeah, I would agree with that, especially when we're talking specifically about the amyloid monoclonal antibodies. We sort of saw that cascade, amyloid first, then tau, and it really seems like the earlier, the better. That said, of course, there's a need, right? And the hope, some of those tau therapies were tested in a little bit later stages, and there's some thought that maybe some of these antisense oligonucleotides may be helpful later stages, but I think disease modification in sort of moderate Alzheimer's disease, unfortunately, a lot of the brain is gone, and that makes it difficult. But of course, there's the need, and but that's quite a impossible, perhaps a puzzle to solve, but a good question. Let's see, we have another question here. Do you foresee these drugs being routinely used in neurology clinics in the near future, or just available in specific treatment centers with behavioral neurology specialist academic centers? It's a really good question. Go ahead, Dr. Sabbagh. I'll let you start with that.
Is this a tricky one? If you want the companies, they wanted every neurology clinic, but I worry that this will be coalesced into the specialty clinics like we did with MS. So a lot of those specialty drugs are only in the MS experts. So I think it could go both ways. I know the companies want it to be more broad, but I feel comfortable when it's in the specialty clinics myself.
Yeah, for the moment, that's true. We're even as specialists right now, sort of somewhat restricted, and we all have to get our sort of systems issues and everything else worked out. So hopefully, at some point, we'll get there. I think blood tests will be an important part of that. Like I mentioned, it's difficult to find PET scanning, rural places, et cetera, expensive. But for the moment and for the near future, I would say mostly limited to specialty clinics, which isn't ideal, but it's a work in progress. See another question here. There was please explain ATN profile lab core. So I'm not sure. You have something to talk about?
Yeah. So you have Quest. We are using LabCorp in our center. You can, ATN would be the amyloid 42/40 ratio, as you talked about. T would be the tau, p-tau 181 is what we have available. N would be the neurofilament light chain, would be ATN on the plasma side through LabCorp.
Thank you for that. Someone mentioned tau surveillance might be helpful to decide about length of therapy. I think that's true. We need to figure that out, but that would be the best candidate. Response to a treatment, length of therapy, et cetera. For example, if you stop treatment and the tau doesn't rise at all, that would suggest perhaps you don't need to treat any longer. But if you've stopped treatment and tau starts to increase, that would be more suggestive that some sort of maintenance therapy is required. So that'll be another piece for us to figure out. Let's see another question here. As for now, if A is positive and T is negative and N is negative, would that person qualify for a disease-modifying therapy?
The answer is yes. It has to just have to prove that they have amyloid. In fact, there's some data to suggest that the A positive, T negative will have better responses to the monoclonals than A positive, T positive.
Yeah, so that goes to that idea that the earlier the better. So, and that's the idea in the prevention trials. The hope is that those people are T negative. Some of them have a little bit of T, it's turning out, but the goal is to look at when you're, only have amyloid before the presence of tau, which again tracks better to the disease progression, that we have the potential to make an even bigger difference in delaying or preventing symptoms altogether.
Yep.
Very specific question here. What diagnostic codes allow for coverage of these tests? Which is a very practical question.
Yeah, so I use a lot of them. I use other amnesia. I use attention and concentration deficit. I use mild cognitive impairment. And there's like 10 codes that actually what I did is I told the LabCorp rep to give me all the codes that they know could work. And then I used the spaghetti method and I just put them all in. And so far it's working. So
Yeah,
not very precise.
it's a bit of a trial and error in my experience too. You know, cognitive concern, cognitive complaints, mild
Yeah.
cognitive impairment. Also, I'll mention for, you know, ApoE, getting that covered is also not a slam dunk at all. It seems to be covered for some people if somebody has dyslipidemia, because it's also involved
Right.
in lipid metabolism, you know. But if you know, previously the recommendation was to not test for it for AN and others because we didn't know what to do with it. But as Dr. Sabbagh demonstrated, you know, it's a risk factor for ARIA, and it does matter now quite a bit, and we need to test for it beforehand. So all these things are in process, and we have the privilege of trying to figure this out together as a field. Let's see. I think those are all the questions we have in the chat for now. I will, oh wait, let's see if there's another one here. If A positive, T positive, would you prescribe disease modifying therapy, therapy, or also if you're all three positive, would you again prescribe a DMT?
I would say yes for me. I don't know. I'm sure you would agree with that.
Yeah, I agree with that. You know, that is more based on the clinical presentation. So if you know, if somebody's ATN positive, but they still are in MCI or a early mild dementia and meet the other requirements, absolutely, I would treat that person. Yep. Someone asked, when will there be an oral treatment?
Yeah, so the drug that is looking promising is a aggregation inhibitor called valproinostate, ALZ 801. They'll report out their data on the ApoE4 homozygotes this summer, and they may go for a label that includes homozygotes and heterozygotes. So my point is that we could see it by the end of the year. We could see some data on an oral medication.
And people are asking for the codes again. Perhaps, moderator, there's some way we can provide those outside of the.
Yeah, we can do that. Yes.
There you go. Yeah, no, that is important. I'm glad that they're very practical questions.
Right.
And that's so here's a good one. What do you tell an 80-year-old, so or older, with A positive only and mild cognitive concerns? What would you do in that situation? So
Sorry, I broke up again. Can you repeat it again?
Sure. So you have somebody that's 80 or older that
Yes.
is amyloid positive with mild cognitive concerns. What would you do in that case?
Well, I would do if they're amyloid positive by CSF or PET, I would talk about a monoclonal antibody. I would look at their ApoE status. I would look at their MRI. I would think about the things we talked about today.
Yeah, so I think I'll respond to this one too. I think this is where that sort of comment about you continue to be a clinician. You know, so if this is an 80-year-old, early stages of disease, no signs of other Lewy body pathology, minimal vascular risk factors, you know, and looks like this is really driving the disease, they meet all the other requirements, and you talk about sort of the risks. And you know, and then you if you're comfortable with it, then making the decision with the patient, having them have buy-in. You know, now the clinical trial, correct me if I'm wrong, went up to age 85. And so you would still be following evidence. I do, you know, it is my opinion that, you know, the older someone is, the more likely they are to have co-pathologies, and might it be the case that they wouldn't benefit as much, or are they more likely to have their disease progress more slowly? Yeah. So do you have to think about those things and have those conversations? Yes. But I would agree with you, if in the right 85-year-old, I would be willing to offer the drug after the right discussions are had. Let's see. So yeah, so somebody said, so basically you complete the workup and you would be willing to prescribe a DMT despite being T negative and N negative.
Yes. Yes. Yeah. In fact, I know those patients might even do better.
That's right. Yep. Let's see if there's any other. think that's most of the questions here.
Okay, good.
Yeah, so these are great questions. I do like that these are being practically applied. And I will emphasize too, this is a constantly evolving field. So even
Yes,
someone like myself who does this every day, but maybe am not specifically a blood biomarker person per se in the lab doing that kind of thing, that these things are changing all the time. There's new data
yes,
coming out. I do anticipate plasma p-tau 217 will sort of be on par with
yes,
CSF and PET scan pretty soon. So stay
yes.
tuned. And I'll give a shout out to allsforum.org. It's a great website that has the most up-to-date information. It's nonprofit. They try to be very objective, and I find it very useful. So if any person is wondering where to find the most update and a source of information, I'd recommend allsforum.org. Let's see.
Okay.
How long? Let's see. Couple more here. I have one specific question about how long would it take to see a patient from Flagstaff if we refer after they have a
Just
plasma ATN profile?
they just have them reach out directly through
The
to
clinic.
us. Yeah,
Okay.
that one we're not going to answer on this
I
one.
know. Sorry. So
It's okay. No,
I
I mean the answer is
agree.
I'm pretty sure I can get them in not months. We'll get them in, but that would just have them reach out to us directly.
I think it demonstrates the issue though, right? That it's hard right now. We don't have access. More broadly speaking, I think we're going to have to figure out as a field how to make sure that experts can oversee as many different people as possible, patients receiving the drug. I think there's a dearth of behavioral and cognitive neurologists. I'm not that far out of fellowship and residency. I was only in the 3 classes of 24 people. I was the only person. Everybody goes into stroke, neuromuscular, other things. I was told you're not going to be able to do anything and you're going to be poor. So egg on their face. But it is an issue, and that figuring out how to democratize access to these drugs is important. I think maybe we're about ready to wrap it up here, unless there's one or
Yes.
more burning questions. But otherwise,
Thank you, Dr. Pruzin, for including me. This is great.
oh, thank you for having me. Thanks to MedNet for hosting this. And I hope people got a lot out of this, both in the specifics and some of the science, but also in a very practical sense. So thanks to
Thank you.
everybody.